Hi, I'm Michael Janssen. I'm a spine surgeon at the Center for Spine and Orthopedics in Denver, Colorado. And tonight I'd really like to open up and discuss with you what the current technology and the evidence for looking at it's cervical disc replacements. Cervical disc replacements has been an exciting technology, and I recently published the long-term results of one particular disc implant, specifically the cervical pro disc, at a 7-year publication in the Journal of Bone and Joint Surgery. At the Center for Spine and Orthopedics, our motto is to provide patients with the most advanced technology and experienced surgical hands. Let's go ahead and start and take a look at some of the evidence on cervical total disc replacement, where we've come, where we've evolved, and where we're at today. Well, first of all, why do we operate on patients with cervical disc disease? Number one, there's two primary goals. Number one is to do a decompression. That means to remove the compression against the spinal cord or the nerve root, and to return the patient to the highest quality of life possible. That may be work, may be recreation, may be a decrease in pain medication, or a combination of both. Now, the standard for the last 50 plus years has been an anterior cervical discectomy and fusion. And as you can see in this slide, this patient has a cervical plate and a fusion expanding over two of the vertebrae following a decompression. I tell patients this is like going to a dentist, but you need two operations. You need A, decompression to remove the pressure on the spinal cord and the nerve root, and B, to do a reconstruction. Historically, a reconstruction was done with bone or a cage, and that stabilizes the neck but eliminates the motion compared to a more advanced technology such as a disc replacement. Now you can see in this evolving slide there has been a lot of technology for disc replacements that have started evaluations in North America through clinical investigation. The one that I have the most experience with was developed and FDA approved in 2008 for the cervical Synthes Pro disc. And as you can see, each of these has some little different designs. Some have a keel, like the bottom of a sailboat. Some have metal on plastic. Some have metal on metal. Some have even polyethylene in between, or a fluid-filled structure to allow the articulation. Just like there are different cars, there are different drivers, there are different technologies, different total hips, different total knees. Each one of these has something unique in the biomechanics, the patents, the materials, which we can each discuss a little bit. Now, what's the real evidence? Cervical disc replacements, similar to lumbar, we probably have more evidence to evaluate because of the extensive FDA clinical trials than most anything else in spine surgery for technology, and they were very expensive clinical trials. Each one of these clinical trials, the Bryant disc, the Prestige disc, the Pro disc, the Kineflex, the PCM, as well as the MobiC, each had different patients involved. Most of those are what we call randomized prospective clinical trials. A randomized prospective clinical trial is when a patient comes in to a physician and gets this pill or this pill. One may be the actual drug to hopefully treat the disease, and the other may be a sugar pill or what we call a placebo. That's not uncommon in medicine, but it's really uncommon in spine surgery or any type of orthopedic surgery without the patient knowing what they're going to get. And in most of all these clinical trials, specifically in the cervical pro disc trial, which I was an investigator in, the patient didn't know what they were going to get until the operation was over. The surgeon essentially opened an envelope either right before surgery or right after surgery and either said perform a fusion or a disc replacement. So when we really look at the results, the patients were truly randomized and placed in a trial that they really didn't know what they were going to get. Now, the primary goal of all of these technologies is a few things. Number one, decrease the pain. Number two is increase the motion, increase the disc space height, hopefully over time have a lower incidence of adjacent disease, and a quicker, faster overall recovery. Now, when we ran these clinical trials, the inclusion criteria, which means that what patients were able to be included in the trial at that time was patients with one level disease. You can see on this MRI with a disc herniation, a patient that had compression of the nerve or the spinal cord, and one of the measures of outcome that we classically use is called the Neck Disability Index, NDI. A patient filled out a form, answered 10 questions called the Neck Disability Index, and they had to have a score of greater than 15, and the patients had to have some conservative treatment that was unsuccessful. We excluded patients that had deformity, because this is not the ideal treatment. We excluded patients with multiple level disease, advanced degenerative changes, bone metabolic disease, substantial obesity, or maybe some allergies to the materials that we would be using. And we randomized them to patients with a fusion. On the left x-ray here with a plate, you can see a bone graft was placed in the spine, and that was a fusion. So a percentage of the patients got a fusion, the other percentage of patients got a non-fusion, specifically a total disc. Do they move? Absolutely. This is an example here on the left side of a disc replacement, allowing that to move, and the yellow dot illustrates the axis of rotation. The left implant is called a ProDisc. It controls the motion over the radius of the curvature of the plastic or the polyethylene. On the right slide with the black background, it was a different prosthesis where there was a ball and trough allowing the spine to change its axis of rotation. This shows some of the motions occurring on a series of x-rays on a patient postoperatively, demonstrating the motion. So one of the clinical goals is motion, one of the clinical goals is function. Historically, for the last 50 years, the primary measure of outcome of a patient with a fusion was, quote, a fusion. Here, the primary measure of outcome is function. Our job is to get the patient functionally improved by treating the disease and to improve the Neck Disability Index. This patient had a multiple level disease and had 2 disc replacements compared to that of having a 2-level fusion. We also want to follow return to work, patient satisfaction of both all of the patients involved in these clinical trials and how much medication they took. One of the other key factors in medicine is we look at a study called the SF36, which is 36 questions trying to look at the overall function in patients with treatments of both fusions as well as disc replacement studies. And this problem, you can see both arrows point to the next disc above or below the previously operated one. And you can see on the patient with the fusion in the plate that the disc is deteriorated over time. It's called adjacent segment disease. We realize that once you fuse those segments, the incidence of adjacent segment disease is fairly substantial, and it increases over time. About 35% of patients by 10 years have symptomatic adjacent segment disease that need additional surgery. Now, what is the primary measure of success? Number one, it's an improvement in the Neck Disability Index. It's an improvement in their neurological function, no serious changes. And in this particular study where the Bryant study was done, 242 patients were in the Bryant total disc, 221 had a cervical fusion, and it was randomized among 65 patients. And here with the graph, you can see that the overall success tended to be much higher in the patients with the disc replacement compared to that of the fusion. When you look at 4 years in this clinical graph, again, the green graph demonstrates that overall success at 4 years with a disc replacement appears to be substantially higher than those patients with that of a fusion. Another disc that was evaluated is a metal-on-metal prosthesis. I'm not a big fan of this technology because of the mechanics, the plates over the front, but it ran a very elegant clinical trial in North America with over 500 patients. And again, you can see that the trend was that compared to a fusion, had a better clinical outcome. And over time, the improvement in the Neck Disability Index between both groups was very good at 60 months. Now, one of the clinical trials we ran here at the Center for Spinal Disorders, or the Center for Spine and Orthopedics in Denver, was an FDA clinical trial where 209 patients were involved at 13 sites utilizing this technology called the ProDisc. And the overall success was compared to that of a fusion versus a ProDisc, where the patients had less secondary surgery, had less narcotic usage, and a better clinical improvement with a disc replacement than that of a fusion. We initially published the 5-year results with Jack Ziegler being the lead author of this, looking at the 5-year results. And I'll comment, recently I just published the 7-year results in the Journal of Bone and Joint Surgery. One of the keys here is you can compare the preoperative assessment of the patient the 2-year and the 5-year continued to trend that there was less disability, a lower visual analog scale, a better clinical improvement, and patient satisfaction with disc replacements compared to that of fusion. There's been a number of other clinical trials, and this is a clinical trial of the Kineflex, and it also demonstrated a higher improvement in the disc replacement compared to that of a fusion. Been a number of clinical trials. This is a MOBI-C. MOBI-C was one of the only disc replacements that ran a clinical trial for both 1 as well as 2-level disease, comparing to that of fusion, of looking at motion, clinical improvement, and overall success. There's been a number of other studies that have compared some of this technology. This was published in the Journal of Spine looking at the PCM disc by Dr. Frank Phillips. It was a prospective randomized controlled trial. And again, the graph shows that the overall success clearly, as all the trials have demonstrated, appear to be superior to that of the fusion cohort with a total disc replacement compared to fusion. Now the key is the primary indication in all of these trials is patient with a disc herniation that's compressing the spinal cord or the nerve root. And it's probably one of the few things that we have is level 1 evidence, which is really to change the standard of care of looking at the best technology over all of these types of discs and their disc implants. Now, what we also found is that none of these discs deteriorated over time. That means that even though the good clinical results we saw at 2 years, they tend to be maintained at 5, maintained at 7 years. So this wasn't just a short-term outcome. It appeared to be a better overall long-term outcome. The reoperation rates, that's the instance at that level or another level, needed additional surgical procedures, was clearly lower in the disc replacement group than it was in the fusion group. Return to work. Most of the studies consistently showed that the patients returned to work at a faster rate with the disc replacement group than in all the fusion groups. So what did we find here at the Center for Spine Orthopedics at the 7-year clinical trial, multiple site study in the United States? Following these patients at 7 years, where now patients that had a fusion versus a disc replacement, we found that the instance that the patient needed additional surgery at the same level at 2 years was about 8.5% in the fusion group and only less than 2% in the disc replacement. At 48 months, 11% of the patients in the fusion group needed additional surgery and only 3%, or 2.9 of the patients that had the disc replacement. And we also can look at those over time, and here's a clinical example of a patient that had additional surgical procedure. How about the arm pain? The visual analog scale for arm pain demonstrated it was consistent at 4 years in those patients between the fusion as well as a disc replacement, as well as their neck pain index and their overall neck disability index. So whatever we saw for early results continued to demonstrate itself at 2 years, 4 years, and at subsequent 7 years for ongoing follow-up. Ask the patients, would they consider having surgery again? Another measure of outcome. And the success rate was quite high in both groups because it improved. At 7 years, we had 103 of the patients that were evaluated. That's 79% of the patients were available for follow-up at 7 years post-op in both the fusion as well as the non-fusion group. And what we found was that the overall success remained about 88.9% in the disc replacements and 86% in the fusion group, with the reoperation rate of only less than 6% in the disc replacement and over 15% in the fusion group. Here's a clinical case, patient from Fort Collins, policeman, detective, had 2-level disease of C5 and C6, affecting both the C5, 6, and C6, C7 level. He had tried conservative treatment. You can see the disc is collapsed at both of those levels and had a 2-level disc replacement. And we have now followed him for almost a decade with what I think is an excellent clinical outcome, no revisions, no adjacent level disease, and or reoperations. So is motion important? Motion, I think, is the primary goal of a disc replacement. It's not to provide motion, but to maintain motion over those segments, as we can see. So in summary, we have had a full scale of new advanced technology for treating patients with cervical disease that we have a lot of experience with all of these types of implants at the Center for Spine and Orthopedics. And as we go forward in the next generation, we may have different materials, different ways to fix the spine, different motions, biomechanics, and one of the key things we haven't really focused on yet is the best way to image these patients. Currently, the most advanced technology is metal on polyethylene, which is probably 90% of all total hips and total knees in North America. Metal on metal, there are a few, but it's a small percentage, and there are some concerns with that particular technology. We may have some new polymers that allow articulation in the future, as you can see here between the Neo disc and the Discover disc, and we may have some combinations of these particular technologies. We also have different ways to fix this implant or give the best ability for the human body to attach to this disc replacement by different ways for ease, but yet at the same time not allow the implant to subside into that of the vertebrae. Some of them will be fixed with screws, as you can see, some of them with spikes, some of them with cutting keels. The key is what provides the best amount of stability to secure these types of devices into the spine after the surgeon does a good thorough decompression. We also have different mechanics. Each one of them has a little bit different axis of rotation. It may have an impact on the adjacent levels. It may have an impact on the facets at the level that was operated on, as well as at the adjacent level for us to consider. But overall, the clinical goals of all these technologies: improve motion, decompress the spine, allow function, return to work, decrease medication, highest satisfaction, and an improvement in the neck disability index. The overall success of all of these technologies have been quite high. Remember that the overall success means that all the criteria were met. So a patient that a prosthesis that has a 79% overall success does not mean that 21% of the patients failed. It means that 79% of the patients met all of the criteria for success as defined by the investigators in the Food and Drug Administration compared to that of a fusion. One of the keys is the reoperation rate appears to be lower in all of these implants compared to that of a fusion. Total disc replacement's not a technology. It's a whole different philosophy of care. Experience comes from bad judgment, and bad judgment in medicine comes from a lot of bad experience. So it's important that surgeons have a lot of experience in this technology because it's not the same as a fusion and you can't get the same clinical overall results. Patients that have not the ideal inclusion criteria can have complications such as this. You can see a fusion was done above. The surgeon probably sized it inappropriately and it collapsed or that dislocated, and these are bad judgment errors. All of these types of complications are generally preventable with this type of technology of new and advanced disc replacements. That's why we think it's important that surgeons are adequately trained, have a lot of experience in this to offer the best technology to patients across the world for this. In summary, cervical disc replacements have improved function, decreased rate of revision, a high patient satisfaction rate, and really the overall evidence demonstrates that this is an exciting technology. And in my past experience in 25 years, it's one of the most exciting technologies we have to offer patients compared to what we've done historically with a fusion. If we can provide any assistance at the Center for Spine and Orthopedics in Denver, we'll be honored to evaluate, give patients advice, and steer them in the appropriate direction or help them find surgeons that have experience in this type of technology. Thank you.